kept this talk quite straightforward. I've kept it quite straightforward without lots of charts and stuff, and that's not because I know that people can't appreciate that, but I wasn't sure of what the cross section of people attending would be, and there might be a fair number of new patients, and I just wanted to keep it quite straightforward and simple, so that and I'm always happy to come back and sort of expand on this at another time. Um, so the main question is, why am I more at risk because of my organ transplant? And it's basically, as you mostly know, I would imagine, because of the immunosuppressant medications, which are required to prevent the rejection of the graft. And they do that by inhibiting cell activation, cytokine production, differentiation and proliferation, all the work that the cells do in our normal activities of keeping us well and keeping us together. It's mainly the cytokine production that has the big effect on skin cancer, because that's the sort of body's early warning system. And the cytokines normally work to prevent the changes which can lead to developing skin cancer. So when they're switched off or inhibited, then obviously our risk becomes greater. But it's not all bad news, luckily. There are certainly, as is often the case in medicine, there are lots of other factors which come into play, and some of which can be to our benefit. So again, I'm sure some of you know these factors and could probably reel them off quite easily. Skin type. Our skin type that is something we're born with. It's part of our genetic makeup, and it affects how the sun, the overall effect that the sun has on us. Our overall history of sun exposure before we had the organ transplant obviously is important. Your organ transplant may have come late, and you may have had an awful lot of time spent in the sun over the years, and that's a contributor. You may have had a prior skin cancer history, so you may have actually had a skin cancer which was treated well before your organ transplant. And when you have had one of these, you're always slightly more at risk of getting another one. The time since the first transplant, because obviously that affects the amount of time that the body is immunosuppressed. So as a general principle, the longer that time goes on, the higher your risk is. The type of medication and the dose is very important as well. So as you know, there are a whole lot of immunosuppressant medications that you can have. There are many that are far more commonly used than others, but the type and the dose, so the levels, which are often start high and then come down, has an effect. And then what you're doing with your skin now, either around the time of since you knew you were going to have a transplant, or since you've actually had a transplant, how you protect yourself and the sort of things the sort of measures that you've taken, obviously has an effect, and also going forward what you do in the future. Please do stop me, by the way. I'm quite happy to be interrupted halfway through if necessary. This cute little slide here just explains skin type. It's called Fitzpatrick skin type. He was a dermatologist who first sort of outlined this. And as you can see, it's types 1 to 6. And basically, as you increase in those numbers, the epidermal melanin is higher. And so your sensitivity to the sun is reduced. So I always like to think of it geographically, really. It sort of helps me remember it. I think of type 1 as being sort of Northern European, usually red hair, freckles, maybe Irish, Celtic, burns very easily. I think Jimmy Connolly always used to make this joke, didn't he? The Scottish comedian, about Scottish people. They're not really white. He said, we're more blue. The skin type 1, is the highest risk, obviously. Skin type 2, I think most sort of Caucasian Europeans would probably be considered about a 2. I always think of 3 as sort of Latin, 4 as sort of Middle Eastern, and 5 as Asian, and 6 as Afro-Caribbean. Now, nobody fits perfectly into all of those, and we live in a multicultural society, thank goodness. So some people will be a sort of mixture of those. But as a general principle, the darker the skin, the more protected you are. But your cancer risk is never zero. So lifetime sun exposure prior to transplant. The sun exposure history is actually counted from childhood, right from the very beginning. And as a general rule, we talk about 3 bad sunburns is considered excessive sun exposure. And I think most people can probably remember at least 3 bad sunburns as a child. So there's a lot of people who've had a lot of sun. Obviously, current or former occupation is also a factor, which is why we often ask people what they do or what they used to do. Did they work outside a lot? Did they live abroad for a long period of time, or did they grow up in a hot climate and then perhaps came to Britain, which is not such a hot climate? But all of what was done in the past, unfortunately, counts. It's all stored in the DNA. Recreational exposure. So what's the sort of things you like to do now or have always done? Do you play golf? Do you sail? Do you go skiing every year? You know, that sun exposure through skiing is just as bad as a sort of Mediterranean beach, really. Skin cancer history. Have you had a skin cancer in the past? We know that the risks that cause that skin cancer are likely to increase your risk to having another. And a marked history of skin cancer in the family. So that's usually considered a first or second degree relative, i.e. parents or grandparents. If one of your parents worked outside all their life and had an awful lot of sun exposure and had lots of non-melanoma skin cancers, it's unlikely that you'd have a family history of skin cancer because the reason for the skin cancer was the sun exposure, not a genetic issue. There are also, some of you may have heard of these, I don't know. They're pretty rare. There are a lot of inherited conditions, and these are just a few. Gorlins, Muir-Torre, Lynch, these predispose people to skin cancers. Gorlins patients tend to get lots of BCCs, and in their lifetime, they may get hundreds of them literally. And of course, BCCs are not life-threatening. They're just an annoyance, and you just keep taking them out, really. The length of time since the first organ transplant, some people, of course, will have had more than one. As a general principle, the risk of developing a skin cancer lesion increases with the progress of time after the initial transplant. And this is, of course, related to the cumulative acquired immunosuppression. You see this often stated 20 years post-organ transplant, almost every patient will have been treated for at least one precancerous lesion or a non-melanoma skin cancer. Melanoma is still pretty unusual in most patients, even though transplant patients are meant to have an increased risk. It's not something that we actually do see that often in the clinic. It's mostly non-melanoma skin cancers, which I'll come on to describe to you. The type of medication given and the dose. And of course, you know better than me that this can change sometimes. Medications can change and swap around. And of course, the doses change over time. But again, there are some that are considered a little bit more threatening than others. Azathioprine and cyclosporine are very good immunosuppressant medications used in organ transplant. Very good. They were used in the past, they're used now, and they will continue to be used. But they do have a bit of a reputation of having an increased risk in long-term use for causing skin cancer. And as we said, risk increases over time, but it can also decline if an organ failed and someone stopped medication and was dialyzing. Then of course that medication holiday would have an effect. Actually, it would have a contributory effect. It would be good, but that break on the overall effect of risk. The good news, and this is always underlying in transplant skin, really, most skin cancers that you can get, the transplant patients get, are generally easily treated with surgery. And if things are quite superficial, we have a lot of topical things that you can use as well. And neither the surgery nor the topical treatments, they do not have an unduly adverse effect on your health. And of course, the other good piece of good news is there are lots of things that you can do to prevent getting them in the first place, which I'll talk about now. Again, I'm sure you know a lot of these. I just wanted to just sort of describe, as we categorize the types of things that we most often see. So actinic keratosis, which is the sort of posh name for sun damage, it's changed cells, cell change due to sun exposure over time, and that's precancerous. So that doesn't mean it's going to lead to a cancer. It could do, but only a very small amount of actinic keratosis will ever lead to a skin cancer. It doesn't look very nice on a lot of people, and it's like can be uncomfortable because it can make the skin feel dry and tight. And you can see it as, you don't always see it, but you mostly do see it as kind of red, flaky areas on the skin, usually on sun-exposed areas. That's actinic keratosis. We call it AK. Bowen's disease is the same thing, but sort of one step up. And whereas actinic keratosis is usually quite diffuse, and I'm going to show you photos, diffuse meaning it's pretty much spread over areas. We call it field change, so you get fields of it, say on the scalp or the arms. Bowen's is different. Bowen's is usually presents in sort of one sort of area, like a plaque. It's quite distinguishable in that way. And Bowen's can sometimes be a bit tender as well. Actinic keratosis isn't tender. The next thing that you most commonly see is basal cell carcinoma. So BCC is in fact the most common cancer in the whole world. It's the most common cancer in mankind. So outside of organ transplant, it's hugely prevalent as well. The statistics reckon now that about 1 in 4 people in their lifetime in the world are getting BCCs now. And that's to do with a lot of things, but mainly to do with the fact that we have an awful lot more leisure time, we get more sun. BCC, so we call that that's basal cell, we call it BCC for short. Not dangerous, not life-threatening, doesn't spread. It's not even reportable for purposes of insurance. So if you had a BCC and you were filling in a travel insurance form and it said, "Have you ever had cancer?" you can say no because this is not counted, and that's a mark of how prevalent it is. If it was counted, it would skew all the data. It is a skin cancer, but it's not treated like one. Squamous cell carcinoma, SCC, that's another sort of step up, different cell type. So it's not related to BCC, but it is in the strata, it would be more serious. We think of SCCs as more serious because they can spread. They rarely do, but they can metastasize SCCs. So we tend to want to treat those quite quickly, whereas BCCs are not urgent. And then, of course, there is melanoma as well, which, as I've already said, you don't often see particularly more of in transplant patients. The statistics would say that an organ transplant patient is 100 times more likely to get a melanoma. But I've been here now for about 8 years, and I must say that's not borne out by our experience. Some pictures now. So this is these are just general pictures that I have sort of stored to show people. This is actinic keratosis, and it can look from anything like that to just simple redness to actual sort of keratotic lesion. Keratotic lesions means sort of flaky, hard, crusty type lesions. So these are sort of individual lesions, but this is a sort of field of them. This is definite field change, the kind of thing that you see on a scalp, for example, and here on an arm. And this, sometimes you don't feel this at all, or sometimes it can be uncomfortable. This is very easily treated. You can treat this topically because this is thin. So if it's a thin thing, you know, cream is able to get in here. The treatment that we do have it for it is not a very nice treatment. It causes it causes a sort of inflammation, and that's how it destroys the cells. So while you're treating it, it's a bit of a nasty treatment, but it is a very effective treatment, and it has no systemic effect on you. So that's good. It's quite a benign treatment in that sense, and you can do it again and again and again. And as I said, this is usually not painful. Bowen's, I remember I just described you more like a single plaque. So this is sun damage as well, but it manifests itself as an individual lesion. And again, you can treat, you can cut these out, and sometimes they do get cut out in surgery, but you can also treat these topically. These are sometimes a bit painful. A BCC. This is a very common appearance of a BCC here close to the eye. You can see it looks like a nodule. This one has got a sort of almost like a pearlescence, a sort of shine to it, and that's very common in a typical BCC. They don't always look like this, of course, but this is a sort of textbook. And this would grow really slowly. You may have had this for about a year before it's even visible, and even then it might be tiny. And this represents no threat to your health. And people say, well, this is really close to the eye. How dangerous is that? This is not impinging on the eye. This is not dangerous to the eye or the sight or anything like that. It's just an annoyance. But cutting it out would obviously it's going to alter the skin a little bit here, and you would get scarring. But it doesn't represent a threat to the eye. This is a common site on the ear as well. Who puts sunblock on the back of their ear? Very common, the tip of the nose. And sometimes BCCs have got this little ulceration in them and they can bleed. That doesn't make them worse. It's probably more to do with the site, really, and the fact that they sometimes get traumatized as well. Not painful. Squamous cell carcinoma, these are different, and you can tell these are different. Well, they look different. There's a hell of a lot more going on. They look they're more keratotic. There's this sort of crustiness about them. These can be tender, so these can be painful, and also they grow quickly. So this can appear and grow to something like this in a matter of weeks, which a BCC would not do. It would be very slow. So that's often helps with your diagnosis before you've biopsied it, which is why we ask people, how long have you had this? When did you become aware of it? These need to be cut out. You couldn't treat this with a cream. They're sensitive to radiotherapy as well. So if someone was really averse to having surgery, they could be treated with radiotherapy. They just melt away. But you need sort of lots of fractions. So the treatment's usually given over 2 weeks, like 10 minutes a day, once a day for 2 weeks. And these just disappear. It changes the skin slightly, but you don't have the scarring that you'd have from surgery. These can be painful. If they're not painful, it doesn't mean it's not a squame, but if there's pain there, then it's likely to be one. I should mention this because you do see this sometimes in organ transplant patients. Kaposi sarcoma. Kaposi with something is sort of, there are two types of Kaposi. There's the acquired Kaposi because of immunosuppression, or endemic Kaposi, which you sometimes see around the Pacific Ring. It's almost a genetic condition, and they are similar, but it's just their origin is different. You often see a single lesion like this, or you can see multiple lesions, and they sometimes look like what we call purpura, which are bruises, sort of browny, purpley color. And again, these are usually cut out, but they are sensitive to radiotherapy. And organ transplant patients, because they're immunosuppressed, can get these. It's not the most common thing that we see, though. So what can I try to do? What can I do to try and prevent skin cancers? It's very simple, really. Limiting your time in the sun. It's as simple as that. Wear a hat and cover up more. Just be much more sun aware now. Taking steps to avoid direct and prolonged exposure to sunlight in the UK and abroad. Some people say to me, well, I say, do you wear factor on your skin to protect yourself? And they say, I always do abroad. And I think, well, the sun doesn't know that you're not abroad. In fact, it's just as bad here as it is anywhere else. So it's just being sun aware wherever you are. Nothing less than 50 plus high factor sun protection, and using it regularly. We say start from about April to September each year. in those months, and carry it around with you. Don't get caught out. You know, people say to me all the time, what's the best one to use? And I say the best one to use is the one that's actually in your bag or in your pocket, the one that you are using. It's no good at on the shelf at home. Reapply it a lot during the day. Never ever use sunbeds or directly sunbathe, unfortunately. And this is not to say that people can't enjoy the sun. You can enjoy feeling it on you, but you just can't be in it for very long, that's all. And we ask people to look at their skin objectively about every 2 to 3 months, because that way you're going to be more aware of changes, things that are different. And as a general principle, we ask people to look at something which may come and not disappear in about 6 weeks. We all get things on our skin like spots or whatever, which come and go. 6 weeks is quite a long time for something to hang around, though. And because you're a transplant patient, we're not going to think you're crazy if you sort of, come to us about the least thing like that. These are the things we want to see. If you cannot identify something as benign, always seek advice. I'm trying to move on to my next slide. Let me just see if it'll go. Let's see. Yeah, there we go. Some useful online resources which you may know already. Of course, Bisky, which is has got a very good website, and it's got quite good patient information on there. The BAD is very good. This hub has got downloadable leaflets, and they're peer reviewed, so they're kept up to date, and you can find information on every specific type of skin cancer that you may be worried about, and it's quite reassuring information. There aren't horrible photographs or stuff like that. It's just got the facts, and it's renewed regularly, and I've put my contact number on there as well. Thank you very much.
That's fantastic, Alan. Thank you so much. We do have a link to the BSSC website on our KPA website.
Yeah.
I'm not sure if we have one for skin health info. Carol will know that, but if we haven't, then we'll put that on as well.
Yeah, it's good. It's the BAD, basically the British Association of Dermatologists, and the patient information leaflets are the best I've seen. You know, they really are.
Great. Okay. It's really useful and interesting information, particularly at this time of the year. I suppose there are some couple of questions that some of us will be thinking about. For instance, how regularly would you or one of your team be seeing a transplant patient, or how regularly should you be seeing them?
Sure. It's not sort of random. Catherine Harwood, who's the professor of skin cancer at the Royal London and has a particular interest in immunosuppressed skin, she's done a lot of work on this, and they basically worked out what was the best way of treating, because obviously you can't see everybody all the time. And some of the Royal London have a large transplant community, just like we do. And so they kind of triaged it. And of course, as I've already said, some of it's based on skin type. So if you're skin type 5 and 6, as a general rule, you don't really need to be seen every year. In fact, you may be able to be seen every 2 years. If the other thing, but a type 1 and 2 should probably be seen every year. If someone has had a skin cancer, particularly a squame, that would push them up a bit, up the roster, as it were, and they might be seen every 6 to 10 months. So that's how we base it. Type 1 to 2 skin, we like to see yearly. Type 4, 5, 6, we would probably see a little bit less frequently. But if anyone had had a skin cancer, especially a squame, we might see them twice a year.
And is there a system that's actually automatically working for the, within the Royal Free, that means that patients could feel that reliably they will be seen, whether
Yeah.
it's, yeah,
Yeah, they have to be referred. So the transplant consultants do, and sometimes the transplant nurses, because they can do it just as well. They do actually physically have to refer patients to us, and then once we take them up, they stay in our system. But not every single person is referred, and not everyone is referred straight away. So for some people, there's a bit of a gap after transplant, and that's fine. But some people, a lot of people are referred to us for other reasons. So they have a different type of skin problem, be it acne or an infection of some description, and or hair loss after transplant is a common one, and so they will be referred specifically for that. And when we've seen them for that, we will probably keep them under monitoring anyway. But as a general rule, we pick up people from the transplant consultants, and they either refer people for a specific reason or just for general monitoring.
okay. So
Um,
so the patients need to talk to their
they do,
consultant, and
yeah,
or presumably if they were worried about anything, they could talk to their lead nurse.
correct. And once they are in the system, which is easy to get into that system, they always have me as a contact or their transplant nurses, because the transplant nurses will often just email me and say so and so's worried about something. They're not due till next year. Could you see them? And then we just do.
Yeah, great.
Alan, quick
Yeah.
question. I take it 5 and 6 is a darker skin, is it?
No,
That,
it is, but Southeast Asian skin, Chinese skin would come into 5 as well, interestingly enough. And you do not see much skin cancer in that
right.
skin type.
Okay, because I used to go every year, then suddenly, since the shutdown,
Yeah.
input up, and I think I've gone through the net where I've been forgotten about it. So
People will slip through the net. Yeah. Why
yeah,
don't you ask one of the renal nurses to email me, and then I will just get you reinstated. A lot of
oh
people sort of fell through the net during COVID
yeah,
because, of course, people couldn't come in, and we did our best with trying to call people, etc., etc. But I think some people slipped out of monitoring during that time, and
okay,
they're still in the Royal Free, so of course it's easy to
yeah,
get back into it.
yeah, okay, lovely, nice one.
Jill, you've got your hand up, and I'll come to Caroline.
Can you hear me? Yes.
Yeah,
Yes. On that, I thought everybody that had a transplant is on the system. I've certainly been going every year.
Yeah, no,
Anyway.
they're not. So they need to be
Oh,
referred, but yeah.
okay. Well, yeah, my consultant did. But I just wanted to ask. My father had what he called a rodent ulcer on his nose because he
Yeah,
used to go sailing. Would
yeah.
that have been a squamous or a
It's a
BCC?
BCC.
BCC.
Human nature always finds different terminology, don't they, to make something sound
Yeah.
better. And we don't use that term anymore. It's the kind of
No, it's
thing
a
they
long time
probably would
ago.
have done in the 60s, 70s, to not say the C
Yes,
word, yes? So
yes, it was sort of
a
AIDS.
rodent ulcer is a BCC.
Right. Okay. Thank you.
yeah. I think it's true that we are using the C word more regularly, but
Yeah,
it's more commonly used referring to Vladimir Putin. It's a different
correct.
C word.
Yeah,
I'm
true. I'm all for that as
sorry,
well, yeah.
sorry everyone for making
Yeah,
Um,
that
no.
rude.
I
No, I'm
just
behind you.
to say that my consultant actually asked me about dermatology this time last week when I saw him, which was the first time he's asked me. But I
Yeah,
go every year, so I assured
yeah,
him that I
Yeah,
go. So
sure. I
they're
mean,
obviously,
we're,
because I've had it for 15 years, my
yeah,
transplant. That's probably why he thought it
yeah.
was time to
Yeah,
ask.
because it's with
Yeah.
time, like as I said, it's as time goes on. I mean, we're very aware that the most important thing is your graft. We know that that's the most important thing in your follow-up care. We're sort of down the list of that, and we
Right.
don't have every patient because not every patient is referred. They may be eventually, but I sometimes think that we probably wouldn't cope if we had every patient at
Everybody.
one time. But
Right.
but it generally works out okay. We tend to generally see the ones that need to be seen.
Yeah. Thank
yeah.
you.
And I have to say that I've had a number of incidents over the years everything has been really adequately sorted out. Most of it's been done at the Royal Free. And as Alan described, some with creams, a couple of things on my scalp had to be removed, but simple procedures that all sound sort of scarier, or the anticipation that was,
Yeah, sure.
was scarier than it actually was, but they were
Yeah.
all a piece of cake.
Yeah.
And I think the message to everyone is that don't think twice. If you're concerned about something, go and get it sorted out before it gets worse, because we're very, very lucky that we've got people like Alan and Farina looking after us and making sure that these things get sorted out. I think that, Alan, we're going to find that a lot of patients have not been contacted. For instance, there's a message here from Caroline that says, I never received an appointment. I was in the system and received one once after months, an appointment at Christmas. I had to cancel it and never got one again. I'm skin type 2. I go once a year now to a normal, whatever, dermatologist to get checked up. Well, that, good for you, Caroline, because that's the right thing to do. Don't mess around, keep getting it checked.
Yeah, proactive. I mean, a dermatologist is a dermatologist, so she's doing exactly the right thing.
Yeah.
But anyone who's fallen out of the system, it's easy. We obviously we don't know if they're. That's the problem. We won't know if they've fallen out of the system. What's easy once we know is to get them back into the system, and they just need to contact. I think their renal nurse would probably be the best route for that, because they just speak to me.
Yeah. Yeah. I mean, another one here from Funmi, who's our vice chair, saying in 13 years she's not been to the skin clinic. But, again, just it would be a shame if any KPA members didn't, in the end, if they were concerned about anything, get in touch with the team. That's the right thing to do. Bruce, you've asked a question here. Will the presentation and slides be available later on the website? Yes to both, because Alan, you'll send me these slides separately.
I will.
But anyway, we are recording this, and so this will within 2 weeks end up on our website via YouTube. So
excellent. That's good.
No problem. Any of our presentations always end up on YouTube.
Yeah.
Has anyone got any other questions? No. Okay. All right. Well, look, I think I'm sure everyone will agree that was really, really useful and interesting. Jill, you've got.
Yes, I just noticed somebody on the chat asking a question.
Thank you. Niti, my mother is a kidney transplant of 20 years. She's developed a lot of skin warts around her neck area. Is this related to the immunosuppression medication? Also, what is the best way to treat it?
Yeah. It probably is. We'd need to see it, but it probably is. Unfortunately, viral warts and what we call plain warts are very common in transplant patients over time. If you have the wart virus before you're transplanted or you acquire it, then obviously when you're immunosuppressed, it can go a little bit crazy. It's a difficult thing to treat, especially cosmetically. But these are not skin cancers, so that's reassuring.
Yeah. I mean, I found after 23 odd years of having had successful transplants that whereas I was born with a beautiful skin, and
Mm.
and it kept for a long time.
Yeah.
Not that it really shows, but I have little blemishes all over, which
Yeah.
if you held a microscope to it, or you look closely, you would
Yeah.
see them. But
Yeah.
you know, I just put up with it as one of the side issues from having taken anti-rejection drugs.
It is, and it
And
really is. Yes.
you know, I put up with any of that if, thankfully, my 2 kidneys have lasted as long as they have.
Yes.
I'm very
Yes.
grateful.
Yes.
Okay, anyone, are we all done there? Great. Okay, Alan, we're really, really grateful. There are a couple of other messages coming through saying thank you, Alan.
Oh, that's nice.
Really interesting, very informative, etc., etc. And we are very, very grateful to you,
Of
Alan.
course.
And no
Thank you.
doubt
I appreciate
that
it.
those people that haven't got to meet you, they've got your bleep now.
Yes.
You'll be driven mad over the next couple
Yeah,
of
but I would just say, so ask your consult if you haven't been referred ever. There's a reason. Ask your consultant to refer you. Thank you very much.
Thank you very much, Alan.